Opiate OD needs observation after Narcan. What are you doing?
Checking the retina for intracranial pressure by measuring the optic nerve sheath, which is, holy shit, 10 millimeters.
He keeps bleeding in his skull, he's gonna die.
Yeah, he needs a 1-inch burr hole in his with a cranial drill. I'm just gonna see if neurosurgery is here.
Holy shit!
Relieving intracranial pressure so he doesn't die.
With an IO drill?
Okay, so basically what's happening in the scene is that the medical team has suspected a patient has intracranial bleeding in the brain, in the skull. So they carry out an ultrasound to measure the optic nerve sheath diameters, and they found out they have 10 millimeters wide of the optic nerve diameters. Therefore, this indicates a very, very high ICP. And so they decided to drill a burr hole over here to relieve the pressure.
Welcome to the physiology part of the lesson. The first word we need to know in this lesson is ICP. ICP, or intracranial pressure, is the pressure in the skull, which is determined by three factors. The first one being the brain itself, which is about 80% of the volume. The next one is cerebrospinal fluid, or CSF, which is about 10% of the volume. And lastly is the intravascular blood, which is the blood from the vein and artery in the cranium, which also accumulate about 10% of the total volume. Moving on to the scene where they measure the optic nerve sheath diameter. In the scene, they measure it and they say it's about 10 millimeters, and they imply it as high. The reason why we can measure this sheath is because this sheath is connected to the subarachnoid space. So when the pressure rises, the sheath will also expand like a balloon.
So there are three types of connective tissues in the brain. First, the dura, second, the arachnoid layer, and the third is the pia layer. Let's focus on the dura layer. So the dura layers is a type of dense irregular connective tissues located in the brain with type 1 collagen fibers for their strength. So when there's ICP, this layer is pushed outward strongly beyond their limit. So this indicates a very, very high pressure in the skull.
Now moving on to the second term is the Monro-Kelly doctrine. So this stated that the cranial compartment is a rigid box contained with the three components as mentioned before. So if one of the components rises, the pressure will rise. The other two will need to drop down. So in this case, the patient has a hemorrhage. So for the patient to decrease the pressure, the body tries to squeeze the CSF out. And then we'll move on to this formula. This is the cerebral perfusion pressure. It is the net pressure of the gradient driving oxygenated blood into the brain tissue. So the CPP, this is the cerebral perfusion pressure, is equal to the MAP minus ICP. MAP is the mean arterial pressure, which is the average blood coming from the heart. And ICP is the intracranial pressure, which is the pressure that pushes back against that flow. So if the ICP gets so high that it's equal to MAP, the CPP will become zero. The blood flow will completely stop, leading to a brain death. This is why the team in the show was panicked, and optic nerve sheath of 10 millimeters suggests that the ICP is very high enough to strangle the blood flow.
So the accident causes the tight junction to break down and the endothelium are damaged, so that the plasma protein can leak out, especially albumin, to destroy the osmotic gradient, therefore causing the cerebral edema and leads to high ICP. And therefore, the doctor in the scene mentioned the use of a mannitol to regulate the osmotic pressure and gradient so that the water from the brain parenchyma cells enters into the intravascular space, therefore reducing the edema.
When the ICP became dangerously high, there is no room for the pressure in the brain. So the pressure gradient from the high will need to move to the low, and that is a process called herniation. There are two types of herniation. The first one being uncalled herniation, which is the temporal lobe being pushed downward, compressing the third cranial nerve, which causes a blown or dilated pupil in the brainstem. Next is the tonsillar herniation. The cerebellum is being pushed down to the foramen magnum, and this crushes the medulla oblongata, which controls the breathing and heart rate, leading to a rapid death.
Hi, my name is Patty.
My name is Al.
My name is Paris. And so today we're going to be reacting episode 13 of The Pits, as our esteemed colleague has already gotten into the informational section of it. We're going to be just reacting on the realism of the scene as a whole. Let's get started.
Opiate OD needs observation after Narcan.
Boring. No, thank you. Mel, how's gone to Grayson?
Oh.
What What are you doing?
Checking the retina
For detachment?
for intracranial pressure by measuring the optic nerve sheath.
Is using an ONSD the best way of doing that?
Well, they're using an ocular ultrasound to measure the ONSD. The ONSD is an optic nerve sheath diameter, and the more conventional way of doing this is to be using a CT scan. This is used because it's fast and standard in trauma, and it shows the type of bleed and the location.
I also feel like before we do the CT scan, we should be going about the trauma assessment pathway first. So we should be going by our A, B, C, D, E. So first, A for airway because we want to ensure that the patient's airway is unobstructed. B for breathing because we want to ensure the patient is getting enough O2 oxygen. And C for circulation, maintaining blood flow. And D for disability because you want to make sure that the brain is understanding and responding as it should be. And E for environment because you want to make sure that the patient doesn't have like any additional injuries and make sure that they're warm.
Yeah, in case of hypothermia, right? Yeah, of course, we want to check for that. So, I don't know. Personally, I think using an ONSD is like pretty valid, no? Like it's an emergency. Like thinking of it from an ethical standpoint, 10 millimeters can like easily leave permanent neurological damage. And we'd want to be thinking of the patient's best interest at the time. Like the severe bleeding and the raised ICP that could cause like herniation, ischemia, and permanent like neurological deficits if the brain tissue face any more trauma.
Well, yeah, that's true. 10 millimeters is a lot, but the ultrasound has a very low sensitivity, also a very low specificity. And it also highly depends on the person using it. The pressure the medical student is applying can alter the measurement. So this means that the ultrasound is very operator dependent.
Shit, 10 millimeters.
What's normal? 5? Yeah, 5. It's an intracranial bleed. The pressure's been building up. There's no blown pupil.
Yeah, not yet, but if he keeps bleeding in his skull, he's gonna die.
Yeah, he needs a 1-inch burr hole in his with a.
Paris, do you think that's right?
Burr holes are basically small holes that a neurosurgeon drills into the skull. The main reason they do them is to relieve pressure from the brain. And this happens when something, usually blood or fluid, builds up in the skull and starts compressing the brain tissue. 10 millimeters is a red flag because the scene shows an unrealistic certainty. The person basically says from 10 millimeters straight to burr hole, and they think it's a quick fix and the outcome referring back to what I said about the probe being specific on the pressure and the angle and the technique.
Yeah, I agree with that. Let's keep watching.
Shit!
Oh my god.
Pressure so he doesn't die.
With an IO drill?
With an IO drill is right.
Yeah, an IO drill is usually used for long bones to drill through hard outer bone. This is a logic jump because from an ONSD to a burr hole, a high ONSD does not immediately mean burr hole. IO drill is not the correct tool to be using because you should be using a cranial drill instead.
Okay, so that's the end of that scene. And I don't know, do you have anything to say about like how misleading that media portrayed that just now?
Yeah, so it's accurate because a raised ICP could be fatal and it needs urgent action straight away. But using an ONSD ultrasound isn't the best thing, but I guess in this situation, since it's an emergency, it could be clues to how you would treat this. How it's misleading is that the scene treats the ONSD number as proof that the brain has a bleed. The ONSD is a screening, not for diagnosis, and the ONSD cannot tell the type of bleed or location, so the better tool to be using is a CT scan in this case.
I don't know. I think that also like what could actually happen if they were to drill a burr hole in like the patient's skull could easily lead to like seizures. Like let's say that the drill did puncture through the skull and did cause trauma to just the sensitive tissues of the brain. That like not only seizures, that could literally lead to permanent deficits. Like the patient could become retarded. Not only that, it could also lead to like rebleeding and infection. Unsterilized condition based off this scene. This happened in an OPD. And we have no idea where they got that drill or whether it was sterilized. Not only that, like it's also performed by a non-professional. It's not a specialist. It's just a nurse.
Completely right. And I'd like to add that because of this unrealistic portrayal, like it this scene could technically lead to public misconception of like what to do in such a situation. People might think that it is like just so simple to go about fixing such a thing and think that, oh well, yeah, you could just drill a hole into the skull, even though that's not accurate at all. And it could lead to patients having false expectations about outcomes. Like they might think that like a bold move or like doing something at all costs will actually save the patient. In general, like such a scene I feel like could normalize unsafe medical behavior, as mentioned by my esteemed colleague regarding
Like they shouldn't be
Yeah.
glorifying like heroic, quote unquote, heroic
Yeah,
acts in
exactly.
like the medical field, right? Because something that one may think is brave would be a very drastic decision if not made like well accounted for. Could easily lead to irreversible harm.
Yeah, precisely. And I feel like patients may start expecting outcomes to be flawless, even though like outcomes end up being imperfect. Patients like they don't always recover like perfectly. Like they even though they survive with, for example, disability. That's what I think about this scene.
Yeah, thank you. And that's gonna be it for our commentary. And just you guys could subscribe, hit the notification bell, and follow us for more reacting content. Thank you.
Thank you.